welcome everybody in the audience here, but also everybody who is joining us online. I hear that 400 people registered, so let's see how many will join us here. My name is Ewout van Ginneken of the European Observatory on Health Systems and Policies. I'm the director, and this is the high-level meeting and panel of our summer school, a yearly tradition that we do together with the Veneto region. It's been a real tradition now. And this year we have a very important topic to chew on, which is health system performance assessment. I think we're going to take a little stock of where we are after 25 years of the concept. Is it really finding its way into policy making or perhaps not? What can we improve? What can we expect? We hope to touch upon many of these issues today. This is a really important topic for us. It's one of the 4 functions of the European Observatory, and we believe it's a key to improve health systems and their performance, obviously. And so I look forward to the rest of the day, and I'll give to the director of the summer school, Reinhard Busse.
Yes, good afternoon, colleagues in the room, colleagues online. We are having this health system performance assessment summer school. We have an annual summer school, as you probably are aware. We have every year different topics. This year, for the second time already, after 2012, we address the important topic of health system performance assessment. We have all week here for the participants in the room who spend all 1 week on the topic on the island. Those of you who can join us only online, maybe you check whether you find next year's topic interesting for the summer school. I can only give you a brief introduction. As Ewout van Ginneken has already said, we are celebrating. It's not by chance that we address the topic of health system performance assessment this year. It's 25 years since the, at least in our circles, famous World Health Report 2000 on improving performance was first published. And the then General Director of WHO, Gro Harlem Brundtland, wrote in her foreword, "What makes for a good health system? What makes a health system fair? And how do we know whether a health system is performing as well as it could?" These questions are the subject of public debate in most countries around the world. And you might wonder, wait a minute, this is already 25 years ago. Have all the questions been answered? No, the questions have not been answered, even though we had 25 years ago this solid basis in our hands. It was a first attempt to rank the performance of 191 national health systems. It identified and measured the performance of member states on key health system objectives, and it examined whether each health system, each of the 191 health systems, was performing as well as it could given existing resources. And it was a ranking exercise, but the most important contribution was the conceptual framework for not only health system performance assessment, but for health systems in general. That the authors at that time, led by Gro Harlem Brundtland, said, okay, we need to separate the functions of the health system. So what is a health system doing? And they defined 4 functions of a health system: stewardship, or what today we would say is the governance, the financing, collecting, pooling, purchasing, the creation of resources, both technical infrastructure resources as well as workforce resources, and finally the provision of services at the core. So this is what we have, the health system. This is like the physiology of the health system. And then we have the goals of a health system. Why do we have a health system? Well, we have a whole health system primarily to provide health. Secondly, but also that the health system is treating people according to their non-medical expectations, what was called responsiveness. And thirdly, that the financial protection, at that time called fair financial contribution, is reached. There was, and you remember hopefully from the previous slide, this efficiency goal, even though not explicitly mentioned on this graph. The performance was, so the goal attainment was set in relationship to the money spent, and that was called performance. What today we probably say is the efficiency. This already explains to a large degree what it is when we talk about health system performance assessment. Here is a later definition by WHO in 2012. Health system performance assessment is a country-specific process. And you see I put this in italics because it is a further development vis-à-vis the first World Health Report 2000, which was a top-down ranking. Health system performance assessment can only be effective, what we believe, and we have good results for that if it is seen as a country-specific exercise of evaluating and communicating the achievement of high-level health system goals based on health system strategies. With the strategies, they mean the strategies to set up the functions, that you add a bit of primary care, take out a bit hospital care, do this and this. So some people also call it the control knobs, where you change the functions. My colleague Peter Smith, with whom I did the previous summer school together on health system performance assessment, said performance measurement seeks to monitor, evaluate, and communicate the extent to which various aspects of the health system meet their key objectives. And the key objectives were these final goals, originally 3. Further developments on the right-hand side on the overall goals or outcomes of the system to be attained, added efficiency more explicitly and at the same level as the other outcomes. And it also added important, what was then called the intermediate outcomes. Health policy makers are rightly worried about access, coverage. We have the concept of universal health coverage as one of the sustainable development goals. We have quality and safety, important concepts which were in parallel to the notion of health system performance assessment developed. So we now have this more triple jump from the building blocks or functions on the left-hand side vis-à-vis the intermediate outcomes to the final outcomes. Further developments, and this is what we use, is a performance assessment framework further developed on the previous versions, which were admittedly looking somewhat easier. This is an extended version which WHO and the Observatory have created a few years ago. It still keeps the triple jump. It has the 4 functions, which are still the original 4 functions of the World Health Report, and opens them. So it says, for example, when you look in the red box under resource generation, it makes it more explicit that we include the workforce and the infrastructure and the technologies in pharmaceuticals. And then it puts the intermediate objectives and the final goals. And as I just said, we have the final goal of universal health coverage with all its sub-goals. The framework also adds connections with the wider society, that we have to realize that the health system is not living in isolation. It both takes outside shocks, financial crisis, pandemic has to take it into account, but it also contributes to the overall societal goals and societal well-being. In the school, we are trying to be quite practical, and this is from my introduction, which I gave to the participants yesterday. I said, traditionally, and starting with the World Health Report, we have looked, so to say, right to left. So we have taken the results, the assessment result of the health system achieving or not achieving the final goals, and then made reference back to the functions on the left-hand side, and indirectly then drawing conclusions of which strategies, which control knobs should be changed. In this summer school, we are also exploring what we feel would be closer to the heart of policymakers, whether we can turn that around. Because policymakers typically start on the left-hand side, say, okay, what happens if I improve primary care? What happens if I centralize hospital services? Will this really contribute to better accessibility, better quality, more population health outcomes, better responsiveness? And we will, over the week still to come, have in-depth case studies on these issues. Finally, so this is what we, the people on the island who are today in this Palazzo del Regione, that's what we have in mind. We want to understand why and how we assess health system performance assessment. We want to appreciate the complexity of health system performance measurement, both in regarding conceptual issues, for example, frameworks, or what we call performance pathways. So if I put in a strategy of more primary healthcare, what does it change along the line? Measurement issues. We have today, this morning, looked at indicators, underlying data. Where do I get the indicators from? And then, very importantly, and today's panel here is part of that, we look at implementation issues, or what we say, the politics of HSPA. Overall, the idea is to learn that health system performance assessment is more than the assessment itself. It's more than a technical exercise. It is useful, country-specific, country-derived exercise, if actually informing health policy, derived from which the health policy makers can derive health system reform, and thus it's like a circular thing. You take the assessment, you decide on reforms, you check whether the reforms work in the expected manner, and go backwards. And last but not least, we want to learn from each other's experiences. We have participants from around Europe bringing lots of experiences to the table, and enjoy the debates, including today's debate. Thank you.
Thank you, Reinhard. And I'd like to, from my side as co-director of the summer school, welcome you here today as well. My name is Dheepa Rajan. I'm also with the European Observatory on Health Systems and Policies, co-host of this summer school with WHO Europe, with the European Commission, and of course this event we're working together with the Veneto region. And we're especially thrilled to be here and doing this with Veneto for the last 18 years, actually, since 2007. This is an important moment for the observatory and also for Europe when it comes to health and strengthening health systems. And this topic of health systems performance assessment is thus particularly relevant. It's as relevant today as it was 25 years ago. We are living in times of budget crunches. We're living in times of perma-crisis. So we have a renewed quest for efficiency, for value for money. We do need to demonstrate that every euro that we put into the system does improve performance. And for that, we need to assess performance. We need to understand what's happening in our system and why, and we need that understanding to actually lead to action. Are we there yet? Perhaps not entirely, but we've come a long way since the year 2000, and we'll debate more about that later this afternoon in the high-level panel. And we'd also love to hear from all of you here today in person, but also online. You are our health community, and we want to hear your thoughts in this area as well. We count on all of you as well to help us collectively move the needle, move forward and advance this topic of health systems performance assessment, because ultimately, and I come back to the title of the summer school, ultimately what we want is to make HSPA, health systems performance assessment, actually improve performance in our countries. So with that, I'd like to hand over to Natasha to say her words of welcome.
Thank you, Dheepa. I'm Natasha Azzopardi-Muscat, and I'm the Director for Health Systems in the WHO European region. And it's my honor to say a few words on behalf of both our Regional Director, Dr. Hans Kluge, and our Head of the Office here in Venice, Chris Brown, who was unfortunately unwell and unable to be here today to welcome you all. Of course, it's a huge pleasure and privilege to be able to be here to support our colleagues in the European Observatory in this 19th edition. As a WHO office here in Venice, we have been here for 21 years, so actually the summer school started only a couple of years after the office was set up. And this, I think, again, pays tribute to the foresight that the Veneto region has had in recognizing the ability of Venice to be a convening point. And I think probably around 1,000 people, more or less, have passed through this summer school over a couple of decades. And this is no small feat. And particularly in these very difficult times, as colleagues have mentioned, the fact that we can gather people from different countries together to learn together, to discuss openly in a genuine way, to share their challenges, their successes and their failures is, again, something to be, I think, extremely proud of and to cherish and not to take for granted. Our office here in Venice is known as a center of excellence for its work on equity. And of course, Reinhard has taken you through some of the key elements of health system performance assessment. And some people believe that when we talk about health system performance assessment, we focus narrowly on efficiency. This is not the case. And indeed, equity is one of the key indicators that many countries need to firmly keep their eye on. Why? Because we will be unveiling our second health status equity report later this year, and it does show some worrying trends. And what does this mean? This means that where we see groups of people lagging behind, where we see inequities widening, this is only problems storing themselves up for the health system in a couple of decades. And I think this really exemplifies why we say health systems and health system performance assessment needs to be taken in the wider political, economic, and social context. So, to close, what I would say is I would like to wish also our colleagues in the Veneto region all the very best with the upcoming edition of the Olympics and Paralympics. As WHO Euro, of course, we stand ready to support from the public health point of view, but WHO is actually far more than just the surveillance and prevention and control of communicable diseases. And we should use such an event to remind ourselves of the importance and benefits of physical activity, of mental well-being, and also of the ability to enjoy the beautiful scenery in the mountains, which of course is also being threatened, not least by issues such as climate change. So this is really what we stand for, and I think that this summer school, although it is focusing on health system performance assessment, is really seeing how health systems are being tested because of the wider issues that we are being exposed to. So thank you very much, Dr. Maritati, for hosting us, and to the Observatory for allowing us to be here with this event.
Grazie, grazie Natasha.
Thank you, Natasha. First of all, I'd like to welcome you on behalf of the local councillor for health, Mrs. Lanzarin, who unfortunately had a previous engagement. She had actually decided she would be with us, but unfortunately the meetings as a regional minister made it impossible for her to be with us. So she has asked me to welcome you on her behalf, on behalf of the regional authority. We also have the General Director of the Local Health Unit of Venice with us here in Venice, who is playing host to the summer school his grounds, as it were. So I'd like to highlight that this event has become for the Veneto region not just a tradition, but something that we cannot do without. This is really very important. Not only is the summer school so important, but even this focus before the summer school in our offices, in our buildings, in the buildings of the Veneto region are all important to us. This is a high-level session of a truly international nature that, in a way, strengthens the relationship we have with WHO, with the Observatory, with the European Commission, who are always active partners to our initiatives. We are always tackling important subjects that are identified year on year that are very important for the sustainability of the future of healthcare systems in Italy and Europe, always with an eye to quality of care, equity, access. And this year, the main focus is going to be on the assessment of the healthcare system. So measuring the performance of a healthcare system is something that we cannot do without anymore, especially so with the planning decisions in view, which is typical for any public administration, be that at national, regional, European level. So getting to know the status quo, the operation, the way the system works is key, of course, to bring about any kind of improvement. Now, if I may, I'd like to express my pride in saying that different models for the measurement and assessment have emerged when it comes to regional authorities, for example, and the units that make up the regional authority when it comes to healthcare. Well, Veneto, the Veneto region, irrespective of those who are being assessed, the Veneto region is always in the top rankings, either first or second and third. So this is something that we're very proud to say. So this means that the Veneto region is always at the top. So the enhancement of the systems, both at community level and at hospital level, that are generated by the Veneto region are usually at the top. There are different ways to measure this, but irrespective of the point of view, we are always ranking among the top 3. Thank you very much for your very kind words with reference to the Olympic Games. So the engine has been triggered quite a long time ago, so we are certainly going to be ready for it, not only in terms of logistics, but also in terms of passing on important messages when it comes to healthcare and the importance of physical activity, as you rightly said. Manuela Lanzarino also have asked me to wish you all the best, all the Director Emeritus and the Director, Natasha, Josip, the members of the Commission. Heartfelt thanks to all the speakers of the summer school, to this meeting, and thank you very much for your choice of Venice as the venue of the summer school. Thank you.
Okay, thank you so much, and we will now go on to the next segment of this event, where we'll be hearing about health systems performance assessment in Italy and in the Veneto region. We heard it was top ranked, so we'll hear some of those details. But I will first invite Barbara Giordani and Silvia Vigna to please come up to the podium and please take their seat. Thank you. So we'll start with a presentation of health systems performance assessment in Italy overall and the different performance monitoring streams. This presentation will be by Barbara Giordani of AGENAS, the Italian National Agency for Regional Healthcare Services. So over to you, Barbara.
Preferisco parlare in italiano perché si tratta di questioni tecniche e non abbiamo molto tempo.
Good afternoon, ladies and gentlemen. My apologies for I will speak Italian because I'm going to expand on very technical issues and advise you. I will speak very fast. We are here to talk about the performance assessment systems in Italy. We do have three tools to assess the performance of health systems. We have the new guarantee system managed by the Ministry of Health, the national program on outcomes managed by AGENAS, and the inter-regional performance evaluation system, IRPES. Let's get started with the NSG, Italian acronym, adopted in 2019 by a ministry decree to ensure to all Italian citizens to receive healthcare services included in the essential levels of care, and which are consistent with the principles of equity, effectiveness, and appropriateness. The Italian regions and the autonomous provinces of Bolzano and Trento in the north are assessed, and the NSYST is the information system managed by the Ministry of Health. The indicators that the new system uses are 88, and they are across the following macro areas: 16 for public health and community-based prevention, 33 for district care, 24 for hospital care, 4 context indicators for estimating healthcare needs, 1 social equity indicator, and 10 indicators for monitoring PDTA for the COPD, heart failure, diabetes, breast cancer, colon and rectal cancer assessment. These are the core indicators which are mainly used. There are 24 of them. They have been identified to provide a concise assessment of the LEA provided by the regions and to guarantee compliance. They are grouped into 3 macro areas. One is community-based prevention, public health, district health care, hospital care. And the other indicators are called no-core indicators. Just to give you an idea of the core subset, the community-based prevention, well, they mainly concern immunization coverage or the participation of women for screening to neck of the uterus cancer. Then we have the MACA, which are assessed in order to see to it the risk of stroke or heart failure or death. We also have some indicators concerning hospital care. The ones highlighted are calculated in the National Program of Outcomes Framework called PNEs. And they are assessed at a regional level, and they are adjusted so that a comparison can be made with the other Italian regions. They are given to the Ministry of Health. A score is given, and this is an important method that we use. Each indicator is assigned a score from 0 to 100, and a score of 60 represents the minimum threshold for compliance. It's called sufficiency, is a pass level. Regions and provinces, to be considered adequate, they should achieve a score of 60 in the 3 macro areas which I indicated for core indicators. This is a mapping of the results that were achieved based on 2023 results. As you see, community-based prevention. The autonomous province of Bozen up north, Liguri region, Abruzzo region, and Sicily are below 60. So they have not passed the test. As for district, Val d'Aosta, Abruzzo, and a part of the southern Italy were not up to the minimum. As for hospital care, we had rather good performance. Some of them are really very, very good, apart from the Aosta Valley, bordering to France. In the north, these are data by the Ministry of Health, and we can get more in-depth data if necessary. As for the National Outcomes Evaluation Program, that was set up and managed by Agenas since 2012. That's a tool to assess the effectiveness and appropriateness of treatments, equity of access, safety of care. The outcome programs focuses on the healthcare processes and outcomes, assessing the public and private hospitals and the local health units. And also the provinces in Italy. Whenever the need is identified to solve problems, audit programs are started with regions and provinces. They are invited to identify the critical points. The National Outcome Evaluation Program contains 205 indicators, 180 concern hospital care. They are processes, outcomes, volumes, hospitalizations. 25 are proxies of the territorial care. They are calculated based on the discharge papers to assess community care. This is what we mean by territorial care. We have the matcha indicators, the avoidable hospitalizations, and the access to the emergency room. Sources and areas is what we call NSIST. It is based on the discharge paper, on LEMUR, which is the Emergency Information System, and on the tax register provided by the Ministry of Economics and Finances to verify whether the patient is alive or not. And indeed, we have all the death dates of patients nationally, also those who have died in the hospital. So for every single record, the discharge form, there are more than 200 variables. And we assess many elements, such as cardio-cerebrovascular, musculoskeletal, digestive, infectious diseases, perinatal and pediatric conditions, respiratory conditions, oncology, urogenital, and mental health. I go very fast now. During the pandemic, from 2019 to 2020, we indeed lost about 3 million hospitalizations. That means minus 20%. That is, in particular, concerning the planned hospitalizations in one-day hospital. That gap has been filled in 2023. However, emergency hospitalizations have gone down. This is one of the many indicators that we use to indicate the differences among different regions. That refers to the perinatal care area. That indicates the differences between the north and the south. So regions do different things. In the south, as you see there, they resort very much to cesarean sections and episiotomies, and they don't use very much vaginal deliveries after cesarean sections. This is the distribution of the percentage of primary cesarean section in private and public hospitals. And you see that private accredited hospitals in the regions of Naples, Calabria, and Sicily use cesarean sections very much. Another important tool which is used in this program on outcomes is the 3MAP. It uses 23 indicators representing 8 clinical areas. There is a score. Dark green means very good, red means very poor performance. These are the different indicators which are used in this 3MAP. Indeed, we can get more data in the website of the PNE. There are different ranges for each indicator, and different colors and scores are attributed based on that. In the end, every hospital or structure have this summary form, and there is a weighted average calculated every year for each indicator for each area. That's a form for a single hospital. In the PNE, we also assess different things. The hospitalizations, the performances, the behaviors and the outcomes and behaviors of different groups, for example, differences between men and women and country of origin. As for the IRPES, a very important system too, this is designed by the management of the Sant'Anna School in Pisa and the MES lab. It is intended to support regions in measuring, comparing, and portraying the degree of quality, efficiency, appropriateness, continuity of care, patient and staff satisfaction achieved. It can be used at regional level, at district level, at hospital level. And regions decide voluntarily to participate into this project. So this is not a national coverage. Only the regions voluntarily agreeing to participate. There are 12 of them out of 20 in Italy. It composes of more than 400 indicators, and there are many different sources because the system has many different dimensions. It does not only assess hospitals, but also the outpatient services, emergency, the use of drugs, and so on and so forth. So information sources are many more as compared with other systems. This system to describe the performance of different health systems, we have a so-called objective with 5 different performance bands from excellent to very poor. And this is the target system used by the Sant'Anna School in Pisa. This is one of the most recent ones. It is composed of different slices with the different dimensions. The different sectors concern healthcare, hospital and community, then the care pathways, quality and safety, responsiveness and user experience, the level of satisfaction by staff and patients, post-COVID challenges, and efficiency. This is what we call DART board in details with all the indicators. It's a weighted average of other indicators And the white dots represent the performance of different indicators. So the more the white dots are in the green section, the better the performance of the hospital or of the region. If the dots are scattered on the red circle, the performance is very poor. Then the target system is used by the music note system to assess the healthcare pathways in the different segments. This concerns the Tuscany region with the maternal childhood pathway where support to pregnancy deliver in the first year of life. Thank you very much. I hope I was able to remain within the time allotted to me.
Thank you, Barbara. So guess you can see the very comprehensive assessments that are done in Italy, the huge differences between regions. And on that note, we'll hear from one of the regions, the one that we're in at the moment, the Veneto region. We'll hear from Silvia Vigna, who is working for the Veneto region for the unit that does the monitoring and evaluation of the regional health plan. Silvia will also be speaking in Italian, so some of you might need your headsets. Over to you, Silvia.
Grazie dell'occasione.
Thank you very much for this opportunity. This is certainly a great opportunity to meet up with all of you. During your introduction, some important things have been said. There are certain things that I have jotted down to go back to certain items that you recalled in your introductory remarks. So one statement that was made is that it's not a technical type of exercise that of the HSPA, and it is good for the healthcare system to see what happens within our healthcare systems. And I'm here exactly to share the daily challenges that we have to tackle to carry out this performance assessment on the part of the Veneto region. There are keywords that I'd like to focus your attention to. One being consistency. We have to understand what type of performance we are referring to, what type of performance that we are assessing. Co-responsibility is the second buzzword because there are many players in this assessment system as put in place by Italy, the Veneto region, and the local health units. And then also the third keyword is future prospects. So how to try to draft a new plan. I'm going in greater detail. What is the performance that we have to measure? Now, only very rapidly, let me hint to the fact that in Italy there are 3 levels. The national level with specific tasks. The national level is where the essential levels of care are to be issued. The money is set aside for this, and the monitoring is carried out. Then there is the regional level, the second level, and of course Veneto being one of the many regions in Italy where the services are to be planned and programmed so that the essential levels of care can be offered. And then assessment and monitoring activity are controlled. Who is actually in charge of the services? Well, those are the local health units who provide the services to the citizens. In this major master plan, there's a level of planning and then a level of management, which is the one that enables us to carry out the assessment and the monitoring activities. At national level, there's what we term as the Pact for Health. Over the last few years, there has been a slight change, and we can say the tool to plan has become what has been named as the Pact for Health. And the Pact for Health, it is written that the regional authorities, by means of an agreement entered into with the state, so regions and the Italian state together, decided that the national plan was in demand to assess the outcomes. The national plan for outcomes is the result of this common decision that has been entered into by the state with the regional authorities. Then there's a programming level, and there's the questionnaire of the essential level of cares. Within this questionnaire, there's a new system of guarantee. The new system of guarantee is the result of the Pact for Health and the need to assess it. Stepping down, there's the regional plan. Each region has to define a social and healthcare plan, because in Veneto you have the social and healthcare joined together to comply with a national strategy. To measure this performance, we have another tool that we use in Veneto, for example, which is the assessment of objectives. This is something that is handed over to the general manager. That is the tool that we use to measure the objectives reached. The local health unit has a tool that derives from the previous tools, and with this, and it has been termed as a single plan of hospital performance, to define the performance as defined in the PAIAO, which is the budget. So there's a list of indicators measuring the performance as defined in the planning document, which is called PIAO. This was a necessary, though lengthy, interaction to understand how the three levels interact. When I was referring to consistency, you have to understand that the objectives of a region cannot but be the consequence of national objects. So our local health unit objectives are, of course, a consequence of what the regional objectives are. Each level has a different role to play and is measured and assessed in different ways. In the Veneto region, this way to define the objectives of the general managers is further organized with three agencies assessing local health units. So there's the regional parliament, as it were, the conference of mayors, which is the combination of the political representatives where the local health unit is offering its services. There are as many as 9 local health units in the Veneto region. There are 7 provinces and 9 local health units. So the objective, as we said before, to comply with an essential level of care is to make sure that within a certain area, all the minimum, the essential levels of care are guaranteed at the same level and with the same performance. Mayors, therefore, are the public representatives of that specific area. So mayors as well are involved in the assessment of general managers of local health units. And then there is the regional council. The regional parliament is basically the combination of all the regional ministers that have been voted, but the regional council is made up by politicians. These 3 actors, these 3 players, contribute in a passing judgment on general managers with different ways. 60% for the Giunta, 20% for the Conferenza dei Sindaci, 20% for the Commission of the Regional Council. Each of them looks at a different perspective. The Regional Council looks and measures based on the planning of the Regional Council itself. The Conference of the Mayors looks at the quality of services as issued within their cities. And the Giunta Regionale looks at the levels of assistance complying with the budget that had been laid down. So you see that there are different points of view, different perspectives, different items being measured. Now, on a practical note, we have divided the system of indicators, it includes as many as 60 indicators, in 4 micro areas. The first area is that of strategic objectives. The regional junta, the regional parliament, has a number of strategic objectives. 33% of the objectives is aimed at making sure that the strategic objectives are reached. So consistency is obtained between what is budgeted and what is actually obtained. 27%. And there are many indicators that have to do with the implementation of the National Recovery Plan or the waiting list, which is a very hot issue at the moment, as well as the implementation of the community reform. So 27% of the indicators has to do with the quality of the services as issued. So not only the 4 macro areas but also support processes, appropriateness perspective in the prescriptions, and all the different areas are looked at with an eye to quality. 25% of the way of the indicators has to do with efficiency. So we wanted to measure the level of sustainability that the region wishes to maintain. We wanted to measure if the cap in terms of the distribution of drugs is complied with, because there are also caps that are set, thresholds that are set, and there are efficiency measurements that are to be complied with. 15% has to do with a new system of guarantee, the one that has named earlier on, where we look at the essential level of care, and they account for 15%. We have defined that for certain indicators that have already been reached, it is one thing. Then there are other indicators where we see that certain local health units do not comply with the level expected, and those are the ones that are measured. Now let me go back to something that has been shown already. This implies basically ongoing monitoring activity. This ongoing monitoring, like the definition of the objectives, is performed in December. During the year, there are 3 or 4 meetings with the local health units where the level of achievement per each indicator is measured. And between July and June, the assessment by the 3 players is put forward. The Conferenza dei Sindaci, so that is the mayors, the Junta, the Parliament, and the Commission. And here you see the level of performance that have been reached. Before 2020, there was a check of indicators at national level based on the level of essential care. But the objective is not to rank first or second, of course, but this may help us in understanding where Veneto is located. Well, over the past few years, Veneto has always ranked among the first. And this has been continued with a new system of guarantee, with new indicators, with fresh indicators. And in 2023, which is the new year, you see that Italy has scored the first position in all the 3 levels. This is something that has been shared already, pointing out to the fact that not all regions in Italy pass the compliance level of 60%. In Veneto, you see that Italy has increased across the board with the level 2 district structures, hospital, and community structures. This is the target, the dartboard, as we've seen earlier on. The new system of guarantee is more connected to a system that was defined nationally and together with the regions, but this dartboard is a voluntary system. So basically, we are willingly contributing our data for this external assessment, and Veneto is proved to have very good rankings going from 2022 to the left to 2024 to the right, and we were always very next to the green, dark green areas, which corresponds to the best area. This is a system that was adopted by the Rome University, with a performance index was decided, and Veneto region proved to be the top-ranking region. One last aspect I wish to cover is how the region has defined its performance assessment framework. The latest plan dates back to 2019 of the plan for the healthcare and social aspects of this region, and this plan wanted to challenge the assessment system based on 4 different points of view. It stated that an external point of view was required, which is the one that we have referred to, the new system of guarantee. In our case, the dartboard, as drafted by the Sant'Anna University, then the system of outcomes, the PNE, and then the system of the citizen, and one that is inside. Well, the inside action is carried out voluntarily together with the Sant'Anna University, measuring the inner temperature, as it were, plan. So basically, a questionnaire is distributed to many of our headcounts, understanding what is the point of view of our employees, so as to try and improve on special focuses. Then let's move on to the point of view of the citizen, which seems to be the one which is most difficult to measure through indicators. With reference to that, the Veneto region has invested heavily over the past 2 years to define a way to organize, again, the patient experience and to record it. There are 2 flows that have been made compulsory. Local head units have to send us information as to the experiences of the patient, defined through a questionnaire together with the Sant'Anna University, through which we measure the experience of the patient, both within the hospital and with the community structures. We have also looked at the communications. There is an office for communications with the public in Italy, which is called URP, and we have identified macro aspects of to measure how citizens communicate with the public bodies. We have defined a very fine tool to measure this communication. This is my very final slide. No, actually, last but one. This slide refers to the number of facilities in red and green that comply with the planning tool called the DM70, or the number of surgery for breast cancer. So there are ever less hospitals performing a few surgery, and ever more so there are hospitals performing a lot of surgery, because again, this was the result of a planning document, the DM70, that is a corollary of the national outcome evaluation. And for the health of citizens, for the patient, it is very important to go to centers that perform many surgeries. So we wanted to arrive at a structure at the national level. So consistency requires a dynamic approach. We cannot stay always still, of course. We have to change on an ongoing basis to update indicators of every system as fast as possible. As for co-responsibility, in order to obtain change, you have to know exactly what is the measurement, the monitoring of every parameter. We cannot obviously rely on monitoring systems giving us data 2 years away. from the time when those data were measured. So we need more timely communication of data, and perspective can only be based if we have tools measuring accurately and consistently all aspects having to do with equity. Otherwise, we don't have a truly structural measurement, which is the one that we need to bring about a real change in our regions. Thank you, and I apologize for taking so long.
Thank you so much. And we do have a few minutes for questions. And I really liked your dartboard visual, which gives us a nice sense of where you're doing well and not well. We have a few questions coming from online, and we don't have a lot of time for questions, but I'd like to take maybe one from the floor and one from online if we can, giving precedence to those who are in the room. Any hands, questions, comments? Please raise your hand. Yes, one in the back, and then after that we'll take an online question.
Thank you very much. Great presentation. When you introduced the very large number of indicators, though you suggested they were based on evidence, and so I was wondering if you could share what was the nature of the evidence on which the indicators were based. Thank you.
Allora,
the indicators are defined based on protocols, and the protocols are validated by experts who can be clinicians, but also experts in healthcare planning. And again, they are validated later and also adjusted based in the different comorbidities, and comorbidities vary depending on indicators. The thresholds are set based on the scientific literature. And again, they are validated by experts at national level. Then protocols are also compared with what is there in scientific literature.
Take one of the online questions. Marina, what are we hearing from the chat box?
Sure, thank you. So the question from the chat box is about the interaction between health and social domains, and they have consequences for the assessment policies. And is this similar trend in Italy? Do you see anything similar happening? And does it pose challenges for the assessment?
Maybe you can answer that. Well, it's a major challenge, assessing the impacts of healthcare on health, and what is suggested by the WHO. It's an ongoing work. I can say that the Veneto region is special since we provide social and healthcare together, and this is part of our history, since we think that the social impact has to be assessed and should be part of the policies of the region. We have a specific set of indicators for that. It's a question mark. No. We are just checking the WHO reports on social indicators. We are trying to think of the assessment of the community and social things.
Sì, l'ultima cosa, anche a livello nazionale.
Well, nationally, in the new guarantee system, attention is given to the so-called equity indicators. An attempt is made to introduce indicators assessing equity. The first one, which will be proposed for this year, is the one concerning those who decide to give up healthcare. That comes from the National Statistics Institute. Maybe it's not the best, but it's a good start. The main problem is collecting data in a structured way. I think that in the coming years, the region of Veneto could provide a lot of data, since we have a lot of questionnaires administered and communications concerning equity.
Data in a structured way is a challenge, and doing health systems performance assessments leads us in the direction of having that structure, hopefully. So thank you so much, Silvia and Barbara. We will now move to the next segment of this event today, and I'll hand over to my director, Ewout van Ginneken, to lead us through the high-level panel discussion. And I invite all of the panelists to please come up and take a seat.
Yeah, and we're waiting, I think, also for Giuseppe. He just left, but he will come back, I'm sure. But please, Natasha, Stefan, and Isabel, you can already join on the podium. Please. Okay, so in this high-level panel meeting, we would like to really discuss where we are with HSPA. A journey that started 25 years ago, and you can ask the question, okay, we produce very nice dashboards, but are they finding their way also in policy making, or do we need to do something extra? Or is it just that we provide a dashboard and then we expect changes to happen from itself, or do we need to do more, right? And I think we want to take stock a little bit and see, some of the developments going on, and also how our panel sees the developments going on. And now my final panelist, who has to start actually, is joining as well. Giuseppe, welcome. Let me introduce quickly the panelists. So we have Natasha Azzopardi-Muscat, Director of Health Systems, right? That's the correct name now, of the Regional Office for Europe from WHO. We have Giuseppe Figueiras, who is the Director Emeritus of the European Observatory in Health Systems and Policies. We have Isabel de la Mata, who is the Principal Advisor for Health and Crisis Management at DG Santé European Commission. And we also have Stefan Eichwalder, who is the Director of Health Systems in the Federal Ministry for Health in Austria. I take the short version, if you don't mind. We also monitor the chat, so Marina Karonikolos is taking care of the chat, so also the people joining us online, please send your questions and we will make sure to get back to those. We have reserved quite some time towards the end to answer your questions. But to start, I would like to start with Giuseppe and a little bit of a historical perspective, if you can. Giuseppe, you've been also around. You saw the 2000 report. You also, as a director of Observatory, you have contributed to the development of HSPA internationally. And I'm really curious to hear from you. Is it delivering on its promises? Do you think we're there where we're supposed to be? And can you give us a little bit of perspective before I start to probe you further?
Thank you. Perhaps to clarify first that I'm too young to be there in the 2000s.
Absolutely.
That was my time.
Yes.
No, really, that's obviously a fundamental question. And what can be very positive and optimistic and very pessimistic, depending on how you look at it. There you are. Age. No, seriously, going back to that. I won't repeat about my dad being in the observatory, so I'll leave that outside. Though I wanted to reflect, as you asked me, about the progress we made since the year 2000. I do think we made measured progress in the sense of the development of indicators. I think we are drawing on indicators frankly, sometimes, too many indicators and not having quite a good understanding of what these indicators tell you and what does it mean for policy making, something that Stefan will be reminding us in a minute, I'm sure, given his position here as a policymaker. I think the World Health Report 2000 broke really new ground in the sense of daring to benchmark member states, which I think has lots of values. I'm sure we'll debate that a bit later, you know, benchmark or not to benchmark, rank or not to rank. Secondly, because gave a coherent framework of the health system and what we've been trying with the Observatory WHO framework to develop much further. This idea that Professor Busse presented so well about the causality, left to right, right to left. No? So too much of what the World Health Report 2000 found there was indicators, and not quite understanding what explains the differences between countries on those indicators. I think we've gone further there, but I think the real debate now is less more and more indicators and much more what are these indicators for, how we use them, how we embed performance assessment in the policy-making process. We have too many reports in many of our member states with beautiful HSPAs that has very little relevance or is not used in ways that are relevant to the policy-making process. I think this is the next step to develop, as well as, of course, to make it relevant, work much more on linking these indicators to priorities, to policies, and presenting. We've been talking a lot in the summer school, more for those who are joining us from outside, about the storyline, the narrative, explaining what they mean, what are the implications for policy making. I made the point, I think, 10 times already. I hope it became clear.
So why do you think that the policymaker is perhaps not always that interested in some of those, for example, dashboard or a ranking? Why doesn't that appeal? What do we need to do then to really get them on board?
A bit what we're trying to do. I mean, here I'm advertising our framework, boss. So I think what we're trying to do, again, is the policymaker gets overwhelmed by this range all these indicators is given. Doesn't see the relevance, doesn't see how these indicators relate to the issues that don't let him or her sleep that night, the policy-making considerations. There is this knee-jerk reaction that we've been working very hard on trying to be, when you're not at the top, you get very worried, depending on the indicator. Sometimes you want to be at the bottom, sometimes at the top. So there's the knee-jerk reaction of saying, oh, I'm not there well, I'm not doing well, I should do like the other country, what does the other country do? The other country does that, I should adopt that. So we need to show the policymaker the relevance of these numbers, help on the nuance of understanding those numbers, linking the concerns. We did a number of policy briefs, remember, we judged with the OECD and the WHO for the Tallinn conference at the end of 2023, where we tried to say, what are your questions on digital health? What are your questions on health workforce? And how we apply these policy questions to performance. How can we tell you whether you improved, haven't improved, and where to improve? And we don't do that.
Not enough, I agree. If there are any, we want to have a conversation here. If you have any spontaneous comment on what Giuseppe just said, just let me know, right? I mean, I have questions for you, but I'm also happy to have an open discussion, obviously. But then let me go to you, Natasha. You alluded before to the fact that HSPA is now more important than ever. And what do you see the developments, and what do you see do we need to include to make it more attractive to policymaking, and that it really can have an influence on policymaking processes?
Thank you, Ewout. And if you found it hard to believe that Giuseppe was around 25 years ago, you'll, I guess, find it even harder to believe that I was around 25 years ago. I was very young, and if anyone wants to know the story behind that, find me afterwards. But I would say that sitting in the Palais 25 years ago, I did have a feeling, as I was sitting listening there, that something important was happening. And the fact, as I was, I think, telling Ewout and Dheepa yesterday, the fact that there are so many trends, so many fads in health policy making, and that HSPA as a concept has survived 25 years and has attracted all of you to come to Venice for a week to discuss HSPA means, of course, that it remains interesting and important. Why? If you ask different stakeholders why HSPA is important, if you ask them why they want to do HSPA, everybody will give you a different answer. People in the Ministry of Finance and Economy will tell you that they want to see where the money is going, where's the bang for the buck. We always put more and more money in, we employ more and more health workers, and how can we see the value of what we are doing? The clinicians will tell you they want to understand how they are ranking, how they are faring. Sometimes they want to feel that their centers are getting very good results. Sometimes they want to prove a point because they feel that they don't have enough access to the right medicines, the right equipment. And of course, people, patients, local politicians also want to get a sense of how they are doing until the results come out. And then everything starts to become a little bit more messy. Because, let's face it, we live in a world of headlines. People just want simple answers. But the truth is that there is a complexity, there is a series of explanation that needs to take place that goes behind and beyond the headline, and we don't really manage to spend enough time with this. The other thing is, listening to the brilliant presentations by our Italian colleagues, I always feel very envious coming from a small country myself, that in a country like Italy, like Spain, you can really discuss HSPA even within the country, because you have different regions doing different things, having different outcomes within a broad framework. For smaller countries, you have to look internationally, it's a must. But this is where it becomes then sometimes politically a bit tricky also for the politicians. And I think as WHO, as public health, we haven't emphasized sufficiently the value of the longitudinal analysis. When you look, for example, at some countries who always feel that they are at the bottom of the pile, but actually when you look at perhaps what they have been doing over the past 10 years, they have had phenomenal improvements and advances, and we don't celebrate that enough, and we don't sell and market enough the value of longitudinal analysis. But of course, with longitudinal analysis then comes the whole issue of consistency. And then we risk getting stuck in a cycle of measurement that doesn't keep sufficiently up to date with the evolving trends. And tomorrow I will talk about, for example, digital, and how do we assess the performance of our health systems in this important new area. So I think these are some of the tensions. How do we balance longitudinal versus cross-country comparisons? And how do we manage to keep consistency in place whilst adapting and evolving regularly to make sure that our HSPA is fit for purpose for the evolving health systems?
I really liked your point about that it means something different to different constituents. How do you get around that? Do you need to bring them all in one room and discuss the results, or do you have any thinking in that, and also the others? Do you have any idea of how to approach that? Because I think it is a real challenge.
So I think we have to be honest. For starters, we have to be honest and recognize that different stakeholders will be looking at the HSPA through a very different lens depending on where they are sitting. But at the same time, I think this is the beauty of HSPA, that there is something really for everyone, because we are looking at the whole and we are not looking just at the parts. I do, however, have a word of warning then about this obsession with trying to reduce and simplify to the extent that we come up with a single index. And I think that was the backlash that Giuseppe and colleagues, who were the pioneers, faced 25 years ago.
Giuseppe, you wanted to come in real brief before we go to Isabel?
I go into a PTSD right now. If I recall the moment, I was the third person in the world to find out in some place in a bar in Zimbabwe from the other two colleagues whose names I will not need to remember, that France was the best country in the world. Which France is a good country. I called my regional director at that moment and said, "Are you sure, Joseph, we can demonstrate that France is the best?" And our regional director was French at that moment. And so that's basically, we can talk about ranking an awful lot. I think it's extremely interesting, and I actually still in favor of ranking. The point I wanted to add, though, I want to echo again and again and again what Natasha was saying. We must have a common framework, at least at a single country level, that can be used by different actors. But this idea, which in the summer school we debated many times, you're a bit fed up already, the fact that you can have a common framework and apply different priorities to these objectives, or different elements, or different needs. But what you cannot do is develop new frameworks and reinvent the wheel for different priorities and different actors, because then we lose the element of a transparent platform to be able to debate with different needs at different levels. And a good HSPA should be able to be applied at the hospital level, primary care level, and should have information for the policymaker, for the minister, et al.
Okay, let's go to Isabel. Isabel, the Commission invests and stimulates HSPA quite a lot through various instruments. Why is it so important to you? How do you use it? And why do you invest so heavily in it?
Okay. I was there in 2000 in a different place at the Ministry of Health in Spain. And well, as Giuseppe was saying, and what I remember is that was something very special, because for 1-2 weeks, not more, but everybody was talking about healthcare, and that, I mean, in the general newspapers of the countries, that was something different, something that never happened before. And the situation was very different according to where the country was placed in the ranking. France, we are the best. Next thing, Spain, we are the 7th. Wonderful. We already said that. We already knew that. Next thing. And some about the results of Colombia, for example, everybody knows. But the lesson that we extracted from that is that for the first time, everybody was talking about that, and healthcare was important. So it's not the reason that the Commission is doing that, but it's also, we need to talk about the performance assessment. We need to explain to the constituencies, to the citizens, and to the health policy makers what we are doing with the money that we are receiving. And we try to improve. For us, for the Commission, it's not important to rank. This is because at the end, everything is artificial. Why is more important to be the first one on financial sustainability, that in response to the attendance of the citizens, or to the different indicators that you have. What is important is that you know how you are doing in comparison to the others, but not to have a ranking, as I said, but to be able to improve. So for us, the group on health system performance assessment, the expert group, that is voluntary, and this is quite important for us. Nobody is obliged to. We try that every country, every member state participate, but we don't oblige them to be there. This is a forum to exchange the knowledge, the experiences that they learn from each other, and that we can also develop and advance. That is a collaboration on strategy and innovation at the end. But I need to insist always that it's not to say I'm the best, it's to say how I'm doing in relation to the others, and how can I improve, and how can I improve, and why I'm not doing better. If I maybe have the same funding, the same number of health professionals, the same structure, what is that make me do in this way or in this other way that makes that I could be doing better?
And how does the Commission use some of those data? Because you also, for example, do the country health profiles, which in my view are small HSPAs that are really helpful, lots of data, comparative information. Is there a way that you already use that data, or is it really for the member states? Or
I mean, we use the data, but also the member state, the state of health and the country profiles. They are another instrument, a different instrument, but that is used also complementary to the HSPA and to the results of the expert group on developing the different activities that we are doing with the member state. This morning, the technical support instrument was presented. How SG reform is working with the member states at their demand or offering to do something together. So we identify with the country profile that in some countries maybe there is a need of changing whatever. Could be the number of health professionals, could be how primary health care is established, could be the hospital. I mean, this is why we have a profile, a number of indicators that repeats every 2 years, but every 2 years also we concentrate in some areas, in the areas that have been identified as most important, mental health at a given moment, or primary health care, or etc. So we use to try to improve the situation in the member state, to support them, but never to compare, never to say you are doing very badly, and just to say, look at that. You have the 27 country profiles, and we don't say anything, but you can compare how they are doing.
You can draw your own conclusions.
Yeah.
Okay, let's go to Austria then, have a national perspective. So Stefan, you are aware of these products, for example, and I was really curious to hear from you how you use HSPA and how you leverage all the new sources of information and how you can really use it within the ministry to reform or enact change.
Thanks. Allow me to start with a set of disagreement, and also with the year 2000, because as you were all referring to the importance of the report, well, I was also around in 2000, but the implication and the impact it had in primary school was limited, huh? Sorry. One should never do that, obviously, but you triggered me now, all the three. Because, to be honest, I found the report really powerful when I learned about it a bit later in dealing with numbers. Now, before directly going to the questions also that you raised now, what we do, maybe also my reflections on 2 or 3 of the discussions or points that were made earlier. I also am a bit pessimistic if I look to the past, because it was such a strong beginning of the discussion with the World Health Report, but then it was very, very diplomatic, saying, well, we could have done more. I think we should have done, and actually we would have been required to do more, but it's a bit this acting in cycles. And this is, I think it was a clear answer to the financial crisis back then, when we, in 2012 also, or when it was decided to have a summer school on health system performance assessment, when there was a lot of discussion after this first immediate discussion after the World Health Report, but it got more quiet, and maybe it also is due to the fact that it's this perfection is the enemy of the good, right? That we were focusing too much on data, on perfect frameworks, on perfect theoretical background, that we too little focused on then the policy relevance, and that was your question to the different ways of approaching HSPA, and I think we need a common approach. Now again, sorry, disagreeing also, Natasha, what you said earlier, that it's wonderful in big countries that you have the country to compare yourself. You just need a fragmented country, so it's also small countries that can do the job, like Austria and Switzerland and others, where you don't need the size, but you could still have so many different systems in place, right? But what I think I learned a lot from one of my ministers was that he was, when preparing data, he was not interested in the ones where it was Austria performing very good. He was really interested in the ones Austria performing really bad. And then he also actually requested us to look into those areas. Obviously, first of all, to identify areas where he also thought we would need to work on. But then also because he said it's much easier to work on those areas, because otherwise how would you justify that you need to bring in change, which we all need to do all the time because we need to adapt the system, if actually you are always on number one. So sorry to say that in this room here, in this region, when you showed the chart, but I think sometimes it's helpful to have this red flag. It's helpful not to be among the top scorers. And we had it in primary healthcare. This is one of the examples where we used the evidence, where we used the international partners, the Observatory, and it pretty much started also with a map where there were, I think, 2 countries in red. One of them was Austria. The other one I don't remember or want to mention here. And it was the primary care orientation. And that was really the reason actually to start and facilitate the discussion. So sometimes it's good, but obviously one has to be brave. And a minister has to be brave and confident in going into those discussions. So this is one of the examples in primary healthcare. Another one is now, and maybe also combining and bridging now the work on the European level and the national level, is on low value care and HSPA, in really looking into areas to see how we can be better in spending money more efficiently, because typically in some of the countries we used to solve and try to solve problems with throwing money at it, right? And that definitely isn't possible in times like these. And we can also not increase the debt. So I think it's a time where we really need to make sure that we use all that is out there to help us be more efficient.
The relevance is clear, but can you talk a little bit more about that process that you then follow? You said we identified it. What happens then? You said you use the observatory, but I'm assuming that you had a sort of a process going on, or is there a framework in place, or a structured approach to it, or how does it work?
Yes, maybe I can steal the 3 I's from one of the Tallinn conferences. I think it was innovate, implement, and include, right? I think, and this might be the question also to how to use HSPA and how we did it. I think you need the first I would be the identification that we already said. So where do we really need to look into? Where do we need to be active? And in the case of primary healthcare, it was relatively clear, but obviously it was still, the satisfaction was high, so it was not obvious. The second I that I would use then is to support an informed discussion and negotiation. So really looking at the data, looking at the international comparison.
With
so
whom?
With the national stakeholders.
Right.
Really bringing the discussions to another level and try to include as much evidence base as possible. Because that is not anything, well, most of you know that obviously, but that comes easily. So it's really this integration of experts from across, from other countries who actually did that. Maybe sometimes it's much more effective to have someone from the medical chamber from Spain or some other country talking to the doctors in Austria or in other countries in making the case that you as a policymaker could never make. So that was the other aspect that we followed in looking at actually who went through this policy cycle, and that is the third I, is the implementation, who actually did it and knows what he or she is talking about. Because if we don't, in the end, after an HSPA exercise, manage to implement, to find a policy relevance and then be better, I think we will never manage to have policymakers being interested in HSPA. So it needs, from the identification at the very beginning to the implementation, and it needs to support those elements.
And a common vision, probably. I see 2 people nodding heavily. Giuseppe wanted to come in?
Yes,
Indeed, I wanted to go into the hot potato ranking, or ranking member states, and when you compare, you rank. When you put any table, Isabel, we agree, you rank whether you like it or not. So ranking is a good thing if you then are able to interpret that ranking, as you, Isabel, said very well, saying on the top and the bottom means very little in many instances. That's why you are there. So the first point to say, the World Health Report and the PTSD I was mentioning about, which actually was a great breakthrough but delayed this work for many, many years, was not because of the ranking of the dimensions. It was because of the indexing. It was because they brought the dimensions together and they assigned weights to these dimensions. At which point you did not know why France was the best country. By the way, many French in the room and online, I love the French system. I think it's an excellent system. My worry was I had to explain why, according to the index that we developed, well, I didn't develop, I was just was junior representing the European region of WHO, according to that, why was France the best country? We were not able to explain, even if it probably was. So we need to differentiate the ranking for dimensions that the policymaker can understand and can interpret. It's the interpretation of the ranking from the indexing. If we had time, I would tell you the story of the consumer powerhouse, my favorites, that disappeared, thanks God, that every time that they gave a report, I had several journalists, and particularly member states, saying, why am I doing not well? Find me an explanation. You know, the ranking of the consumer powerhouse was based on a bunch of doctors, I'm a medical doctor, by the way, I can say that went in some island, I think it was Malta, by the way, cardiologists, endocrinologists, they put them together and said, how would you rank? How would you weigh these different elements? And this index that was so influential, do you know that in that index, no one realized, apart from some of us who wrote some articles, that you had the same weight for accessing to some pharmaceuticals as your life expectancy. So according to that, to live more years was equal in terms of weight of the consumer powerhouse index as having access to a pharmaceutical. You can see the vested interest behind that. So that was the issue, which was not in the case of WHO, by the way, that killed the whole thing. And it took us in 2017 that actually with the health systems reports, country profiles, we dared to go back with the Commission to actually do what's a performance assessment. And we realized that member states love it. They're really interested. They're not afraid anymore of ranking. This is something we created ourselves. Some of us, even in the academia or no academia, member states like to be compared with each other when you're kind, when you're careful, when you interpret well.
Natasha,
let's disagree. Let's disagree.
It is true that we rank all the time, obviously, but for indicators, but not composite rankings or indexes. Yeah.
So a couple of points. Being at the top of the list can also have a negative impact. In 2000, Malta placed 5th in the world, tiny country, 5th in the world. That meant every time, for many years, we went to the Ministry of Finance to invest, we were told, sorry, health is fine, we have other priorities. So that's, sometimes be careful what you wish for. On the consumer powerhouse, I was chief medical officer in my country then, so it was always a very, very tense moment, but that's where you realize the importance of being honest. So I come back to my point about honesty, honest, transparent, and consistent. Because what were we doing? We were looking at the consumer powerhouse in the ministry thinking, okay, we haven't done well here, we haven't done well here. Maybe it's true we could do better here. So we worked really hard on those 3 areas, only the following year to realize that they've completely changed the basket and the weightings. And then we were, again, snakes and ladders back to scratch. But the real point that I wanted to make was in relation to some of the points that Stefan brought up around the Tallinn, because he reminded me about the last Tallinn conference where we talked about trust and transformation. And I think when we talk about performance assessment, why are we investing so much time, so much energy? It's a laborious, expensive, difficult process. It's because we want to use it to transform our health systems for the better, not just for to have a published document, but to use it really to transform. But systems don't transform themselves. It's people who transform systems. And this is why I go back to where I started. Unless we manage to bring together the funders, the clinicians, and yes, even the patients, because sometimes it's patient behavior and utilization that needs to change in order for progress to be made. It's not going to happen. But to be able to do that, people need to trust the system. Now, something that we haven't spoken about is the fact that maybe a bad rating in some area also instantly, in this open world that we are living in, breeds mistrust in the system. And in a world of cross-border care, also leads to a situation where those who are literate, who have the resources, will go to the better regions or will go outside the country to other countries. So yes, we want to trust, we want to communicate, but we also need to be wise to anticipate the impacts and come round again to the fact, can we use this HSPA to actually transform system?
Thank you. I think we open it up now for you, for questions from the audience, before we also ask for questions online. So are there any questions here? Have we answered all of them already? I cannot imagine. There is a question, Lucy. Maybe you want to say who you are and your name and affiliation.
Hello, my name is Lucy Brindova. I'm from the OECD Health Division. Thank you for this very insightful and inspirative debate. I must say that there has been a few things that kind of resonate, not only in here, but also in other countries and organizations. So what you've mentioned several times is that the beauty of the HSPA is perhaps in that everyone can find themselves in it. And this is what I believe is super important, having all the stakeholders there throughout the development process of HSPAs, not only as final users, but being actually part of the development. To say that, I was looking the whole time at the title of today's discussion, and was thinking there is perhaps something missing in the words, because health system performance assessment per se cannot improve performance, right? It is a tool that we use for different purposes. Mainly we use it for monitoring, that's true, but we can use it to actually get the knowledge on where the performance can be strengthened or improved. And you said it nicely. We also are discussing it during the summer school and on other fora, but I would like to just say that actually to use that tool wisely, or to actually have use the power of the tool, we again need the stakeholders. And here it also comes not only to the technical part, because it is a technical tool, right? But to the policymakers as well. So it's about how do we embed the HSPA intelligence into the country's decision and policy making. And this is what mattered the most. And this is where the HSPA can actually improve the performance through. So
that's the okay. So that's the question. Are there more questions so we can take a few? I mean, it's coming back down to where we started our discussion on, how do you make sure that there's a process in place for HSPA to, to have a role in the system. Other questions that I can bring to the panel. Over here. Name and affiliation.
Nahida Al-Lawati from the Ministry of Health of Sultanate of Oman. Thank you very much for the beautiful and insightful and stimulating discussion, but it made me raise a question about the role of transparency and the importance of sharing the results of the HSPA with the community and with the different sectors, and whether it will have a negative impact or not.
So a question about transparency and a question about embedding, and I think you already had, or did I misinterpret your nodding earlier?
I was not sure if you're looking for answers.
No, they won't love to start, I think, Giuseppe.
You know me. Actually, thank you. Thank you, because that was our 30. Trust, transformation, and transparency, remember? We didn't make this explicit until later, but we felt that you cannot transform, you cannot get trust unless you have objective transparency. And I know I sound naive, but I learned over the years that at the end of the day, even the minister in charge that doesn't look very good today, that transparency will protect. If you protect that transparency, will protect this minister when he's out of office and comes back or criticizing the next government. So that transparency in a populist world, where anyone invents anything and has a go at you, where everyone ranks, when everyone publishes or not publishes, that serious, rigorous transparency by these international organizations is a measured protection for the ministers and for all these actors that need to play together. And Lucia, I couldn't agree more with you. That's the story of our lives, isn't it? Is how do you embed data into the system? And I could go into some countries where I've been very impressed about the way they did it, but most of them, HSPA is done by a bunch of analysts that have a lot of fun. They publish it every year. Sometimes it's covered by the press. That's why benchmarking, naming, and shaming sometimes is a way to get attention from policymakers. But it's too far from that policy decision-making process. And this is part of our story in the Observatory, looking at evidence organizations. Ewout has been too far, too far, too far. I don't trust them. Too close, too close, too close. I dominate them and I tell them what to say. So finding this HSPA that is independent enough, transparent enough, explicit enough, and linked to the policy decision-making process is the center. And we can talk about some countries where they manage that, but that's where we all should try to work hard, not only indicators and frameworks, although I'm a framework freak as well.
Any other comments? Yeah, Isabel?
Yeah, I mean, it's not the HSPA what is going to improve the performance of the system, but it's the reaction to the HSPA, to the reaction to the tool. Because what you don't want is that you have been put in a situation where you are not performing well, or where you are told that we don't know how you are performing because you don't have the indicators, you don't have the data. So it's the reaction, and this is why we need to continue to do that and to insist in that it's important, the assessment of what you are doing, because otherwise you cannot improve and you can go worse. And this issue that is not, I mean, it's ranking nobody likes unless you are the first in the scale. But comparison, yes, everybody wants to say that I'm better than the neighbor, or that I am not the same level that the others. But even sometimes also to say, I'm not so good, but I am not interested in being so good. We have, for example, this ranking of the universities every year. I mean, it's very nice that Harvard is always the first one, or Oxford, or whoever. But I am not interested in going to Harvard. I don't want to pay the fee that I need to pay for that. I prefer to be with my university that is not maybe so excellent, but is excellent enough for what I can afford and what I am going to perform. So, I mean, I think that this is just, as Lucy said, this is a tool, the HSPA. Then let's see how we are going to use the tool. But we need to use the tool.
But in some cases, perhaps the data can be better presented. That was the point that you were making earlier. You can show maybe the improvements, which can be rather large from the countries that are on the bottom of the table. And I think that is a really important finding as well, and a positive one. So it's really about packaging, but you wanted to come in as well.
Yeah, no, I think on this what I would say is that we need to be able to tell the story. HSPA, reams and reams of data, tables and figures need to be able to be woven into a story that explains why things are like that, but a story that also allows people to believe that things can be different, can be better, and gives them the agency to make this happen. To some extent, I think that perhaps we have been a little bit elitist because it is complex. I mean, I've been around for long enough to have done many things, and one of the things that I did once was to help a colleague and be part of a working group for our first HSPA in Malta. And even with a group of data geeks, public health experts, it was very, very difficult, laborious, and complex to come to grips with it. So I think because we know that this is not so simple and that it is complex, we also sometimes keep it a little bit to ourselves and say, okay, the clinicians, actually they won't understand it. I mean, the public, they will misunderstand it. The media, they will exploit it depending on whether they support the government or they are affiliated to the opposition. Yeah. And I think this is what we need to do. We need to take HSPA to parliaments. We need to take HSPA to the communities. We need to find a way to be able to, in this world where everyone wants things to be simple, to keep the complexity in the background, to know that we are doing it well and rigorously, but to find a way to tell the story in a simple sense.
But is it also about providing the right background information, which can often be also qualitative? I know you've worked on health system transition profiles, broad reviews of health systems. Isn't that also the kind of information that you need to be aware of and know to be able to interpret the results of an HSPA? Yeah.
Absolutely. And this is basically the call to public health leaders. Yeah. I think, again, we have tended sometimes to separate too much public health and health systems. And we say, no, public health, we talk about tobacco, about alcohol, about smoking, all of which, of course, have impacts on the health system. But actually, we need the public health leadership to be leading also the health system.
Stefan?
Maybe I can quickly add addressing both topics at the same time. Because I do think that also given the current difficulties and constraints on our budgets and so on, HSPA activities, HSPA or similar activities, I think we also have to be quite careful not to, if we talk about the HSPA, to see this really complex framework as the only answer to it, but then really the core elements, as you said, being maybe really very clear in the background and very comprehensive, but then very basic in with what we go into parliament. Because if I go to parliament with the big framework, I lost everyone at this first slide, right? Because that doesn't make sense, and it's not necessary. So the question now is at the moment with budgetary constraints, evolving healthcare needs, global threats, also health security threats. They all highlight the need for a better informed decision making, and also the possibility of then implementing, which requires trust and transparency. So in the end, I think also this concept that we discussed already in summer school with this patient, this performance pathways, where we really look not only either to the very left, how much money do I put in, and then see the healthy life years as an outcome, but really following the system. And I think we just started that in summer school, but for me that could be, if we manage, a game changer in the use of HSPA, because then you can inform also your policymakers, you can inform the public much better if you are able to follow through the system and look at the interfaces, and also be able to be better in saying what will be the implications of a variety of measures. Because typically that is something we often miss, and then we do it ad hoc, but not following a clear structure. And for me, that could be really one of the important aspects for HSPA, to make sure that they gain the policy relevance they need. And maybe to the ranking, a last word, I just like this, and I typically have it in presentations often. There's a ranking from the Commonwealth Fund some years ago. And since France as a country was mentioned many times, it ranked almost last in all dimensions: quality of care, access, efficiency, equity. Almost everywhere, almost last, but then it was on number 1 in healthy lives. So it's an interesting approach, and then the other side to the coin is the UK in this ranking, which performed everywhere on all dimensions on number 1, but on the last one on healthy lives. So it's really also the necessity of then putting things together, being able to prepare it, and also acknowledging that particularly in health there is so much happening outside the narrow health sector that should make us cautious when we do those exercises.
Absolutely.
I think
yes.
Very important what Stefan has mentioned, that different people need different reports. So because I already had this experience that after slide 2 I'm completely lost, so my commissioner is even more lost, or some of the politicians. So what Natasha said, that if you explain very simplistically, saying, "Oh, you are the best," and we had the same experience in Spain. You were the 7th one in the classification. So why you complain about the money? You have all the money that you have that you need because you are nearly the best. So how to explain the things to different constituencies in order that they can understand, that they can not take the wrong conclusions on that.
Okay, very briefly, and then also very, very briefly, Giselle.
Very briefly, because Stefan mentioned an important point which I wanted to mention earlier, health security. So, health security is on everyone's agenda at the moment, clearly. Years ago. But basically, the point that I want to make is that we aren't advancing in terms of our health security preparedness as a European region. Our last European health report shows this clearly. And I think it's because we are failing to make the link between health system strengthening and transformation, and the fact that this is needed if we want to improve our health security. And this is an important political hook, I think, in the current climate.
Okay. Giuseppe?
One dimension that I wanted to comment that, and Natasha was raising very well about Malta doing very well, therefore not needing more resources, is what we developed in our HSPA. We had great debates at Dheepa about the impact of the health system on societal well-being, on sustainability, on environmental, economic sustainability. So linking those goals to those broader concerns of our policymakers today can give us also a great rationale and justification to invest in the health system. So health systems performance assessment has to go beyond those goals and then demonstrate the linkages with these goals with our society goals. That can empower us in the health systems to make a better case to invest in the health system versus other areas. And remember, not only in terms of the health status, I'm talking about the role of the health system, what we call in the Observatory Ewout, is the health for all policies, not in all policies, but how health can support gender equality, can support poverty, or the opposite, can support economic development, and the health system itself, it's a tool to decrease the carbon impact on societies, and so on and so forth. And that part of HSPA is fundamental to develop as well, and we're trying hard with you at the leadership.
Yes. Now, Marina, to our online audience, have there been questions? I can come to you if this is the only one, and I'll just run to you, Marina. Or maybe you can also come to me, and then I don't have to do all the running. Oh, you have to read, sorry. Yes.
Thank you, Ewout. So, can I combine a couple of questions together? Do we have time? So, one is on what is the role of municipalities and communities in strengthening health systems, and it was asked in the context of increasing centralization when local communities are given less role, but the centralization makes the more challenges at the same time for health within these communities. So that's one. And another one, and there the audience calls you seasoned panelists. If you are given in 2025 a clean slate, what would HSPA now that you would design look like, considering all the complex landscapes for the health systems?
Okay, so you heard the two questions that came from the chat. One, a clean slate to do whatever you like. Who wants to react? You must have ideas, Stefan, because you are in that process.
No, the question is if I understood it correctly, the health system that we could, no, I understood it correctly, but the difference is, do we talk about a health system with no path dependency and a new ideal system in a new kind of world? Because otherwise the HSPA, so for me what I already said, given a system is really allowing us both to identify the areas we particularly need to look at in order to improve, where we have weaknesses, where there is also room to improve, where it makes sense. And on the other hand, and I think this is maybe the one element that is quite difficult in the most HSPA, also why Lucy was mentioning it, that is supporting policy measures by actually showing what are the implications. So if we have all this information and then maybe really from all these reforms in different countries and similar experience where we are able to better understand different possible outcomes of measures, because I think many times we do not always we are not always able to manage or to foresee what the implications most likely will be. And if we could strengthen that with an HSPA, then I think all politicians and policymakers bought in already.
Yeah, there was also this question about the municipalities, but go ahead, Natasha.
No, I think on the municipalities, clearly, there is a role. They have to be involved. When we talk about involving communities, we have to involve municipalities and particularly cities and larger cities. There's definitely a role there. But I wanted to come back to perhaps what my wish list would be if we could do something different and to think perhaps about being a bit bolder here. I would say when countries come to plan their economic and financial strategies, would they do that without considering the economic indicators? In the same way, I think we need to make it clearer that when we come to make decisions about investments, infrastructure, reforms for health, it is still too optional to determine the extent to which we allow health system performance assessment, which is really understanding the story behind the data and the metrics to influence decision making and planning and programming and investment decisions in health. And this is where we come back to the old adage of, is it science, is it politics, and how do we blend the two together? And I think we need to be real about, and I come back to my honesty, HSPA is a combination of a scientific and a political process. And this is, I guess, what I would say. If we could rewrite it again, we need to acknowledge that it is the bringing together of the scientific and political process. But it would be good if there were a mechanism to, in somehow, mandate that health investments, health reforms, health decisions are linked and based to the data and HSPA.
Yeah. Giuseppe?
Yeah, my clean slate is not one of these cases that you need a clean slate to develop the new model, perfect model of HSPA. My clean slate would be on the following, like my sister here, as always, we agree with each other, on the governance of HSPA and the role of HSPA in governance. My clean slate would like to be in redesigning, and that's very political, I know that, the way that HSPA is embedded into that system as we kept repeating it, in the way that participates in the governance and we can govern HSPA in different ways. That would be my clean slate one. The clean slate two would be to teach all of you Some of you are very good, some of you are good as well. Communication. You love, some of us love to do research and methodology. If you all, my clean slate would be to go together and learn, which is what Natasha is reminding us, how to communicate, how to explain. And I like to finish with the storytelling, communicate, which was the 3 lessons of COVID, by the way. On the municipality, certainly all the research, Natasha, you already pointed to that, tells us that changes in public health have to be at municipal level. This is where the determinants are, this is where you can act, this is where you have the social, the economic, the urban, the environment, and so on. The Healthy Cities, one of the oldest programs of WHO, is actually one of the most innovative ones still now. And the same with PHC.
And it's coming to Venice as a result of the restructuring.
It was all prepared, that, you know. She said, say that, so I can say that. No, not true at all. It's a duo. And the other one is PHC, of course. PHC integration. PHC, and let's go back to Almata, what the hell. Let's go back to Almata and say that actually PHC, not being at the center of intersectorality, not always agree with my colleagues in WHO, but can play a huge important role in supporting intersectorality, in addressing determinants, particularly when PHC is integrated with the municipality authorities and so on. So I think tries to reflect a bit that question, a very important question about decentralization.
Thank you very much. I don't think, is there one last burning question? Is a question or? No more comments? If there's one question, no? Then I think we stop here, and I want to thank the panelists for their contributions. Yes, applause. And I give the microphone back to the director of the summer school, Reinhard Busse.
Yes, thank you, director of the observatory. Thank you, panelists. Thank you all in the room. I think we have some exciting days in front of us where we dig deeper, and we have the promise here. And I think we have the promise, even though not the proof, that health system performance assessment, that it actually has at least the potential to actually improve performance. Not only the assessment per se, but the good usage of the assessment to then play back. We will have interesting examples both on certain domains over the next days. You people out online, I hope you regret that you haven't signed up for the whole summer school. It's really interesting. You have laughing and cheering and very well, some of them very well, some also very, very well participants here. And I think this was a great discussion. Thank you, panelists. And I hand it over to our local host.
Grazie anche.
Thank you very much. Thank you very much. Congratulations for the high level of the discussion. Congratulations to all the speakers. HSPA is extremely important, nationally, regionally, and at different hospitals. If I may, okay, I'd like to add something. Don't be afraid of comparison and benchmarking. You know, 15 years ago, indeed, the idea that all the data were covered, it appeared like the third secret of Fatima. Now we are no longer afraid of comparing. So enjoy your stay. I also would like to thank the interpreters. Thanks also on our side. I'd like to thank the interpreters for helping us to understand each other, and enjoy your stay. Thank you.
you.